Okay, I think I'm going to get us started. Welcome to our symposium on adapting medications for opiate use disorder in the criminal justice system. And thanks to everyone who's joined us today to discuss this important topic. My name is Colleen Berry, and together with Liz Stewart and Beth McGinty, I direct CMAP, our Johns Hopkins Center for Mental Health and Addiction Policy. CMAP is a school-wide initiative focused on policies to improve the lives of people with mental health and substance use disorders, and the sponsor of today's symposium. Jails and prisons are a critical setting for thinking about the role of policy in improving the lives of people with substance use disorders. More than 50% of incarcerated individuals have substance use disorders, and there's an increasing set of opportunities through federal and state policy to improve post-release services, including through Medicaid, thanks to extensions of the Affordable Care Act. The ongoing and devastating national opioid crisis heightens the importance of facilities being able to deliver evidence-based services, including, critically, FDA-approved and life-saving medications to treat opiate use disorder. Today's presenters will highlight findings from a series of recent studies. They are Brendan Saloner, who's a core faculty member with CMAP and associate professor in our Department of Health Policy and Management at Johns Hopkins. Sachini Bandara, who is a CMAP deputy director and assistant professor in the Department of Mental Health at Johns Hopkins. Noah Krawczyk, who is an assistant professor of population health at NYU and a proud alum of Johns Hopkins, and Alene Kennedy-Hendricks, CMAP's deputy director and assistant professor in the Department of Health Policy and Management at Johns Hopkins. I'm pleased to also welcome our two discussants today. Alexandra Duncan is Senior Officer of the Substance Use Prevention and Treatment Initiative, and Tyler Winkleman is a physician and health services researcher at Hennepin Healthcare and treats OUD at the Hennepin County Jail. Please put your questions in the chat. We'll take questions from the audience at the end. And with that, it is my great pleasure to turn our virtual podium over to Brendan Saloner to get us started. Brendan.
Great. Well, welcome everyone to today's event, and thank you so much for that introduction and for being with us. So I'm just going to briefly frame today's discussion and turn it over to my colleagues. Next slide, please. So first, I want to acknowledge a couple of funders who have supported today's presentations and the research. Arnold Ventures and Bloomberg Philanthropies have been big supporters of our work. And just to offer the disclaimer that the work presented today represents our own views and not necessarily those of our funders. I also want to offer a heartfelt appreciation and thanks to Sydney Merritt, Nicole Mosley, and Caitlin Hoffman, who have helped to make today's event come together. Next slide, please. So why today's event? Many of you may know this, but there is a huge often missed opportunity to save the lives of people who are leaving jails and prisons. This is from a famous study published in 2007 in the New England Journal, showing the heightened mortality risk in the 1 to 2 weeks following release from prison. What you can see here is a massively increased risk compared to the population average shown in the dotted line. And most of these deaths actually attributable to substance use and to drug overdose. Next slide, please. So many problems facing our country right now, but one of the small good pieces of news in the opioid crisis, actually not so small, is the fact that we have highly effective medications for opioid use disorder. And the title, I think, says it all from this 2019 report from NASM. So we have 3 FDA-approved MOUDs, methadone, buprenorphine, and naltrexone, all of which has substantial amount of evidence supporting its effectiveness, especially for buprenorphine and methadone. We have a lot of evidence showing the reduction in overdose risk compared to non-medication treatment, and also improvements in quality of life, lowered risk of infectious disease transmission, and reduced criminal activity. Next slide, please. We also know from a very important study published in 2018 in JAMA Psychiatry that after the Rhode Island Department of Corrections adopted all 3 forms of MOUD, they saw a dramatic reduction, about 2/3 in post-release mortality. Next slide, please. So this brings us to today's event. So we have this fledgling movement underway right now. And according to some recent data from Brown University's Prison Opioid Project, about 9% of all carceral facilities in our country now offer at least some form of MOUD. Now that may seem small, and I think it is, but it actually represents substantial improvement from where we were a few years ago. So we are seeing a lot of growth in this area. We've also seen tremendous amount of support for offering MOUDs in jails and prisons from SAMHSA, the National Governors Association, the American Corrections Association, and other major entities. Next slide, please. And I think we can learn a lot from how these different facilities have gone about implementing programs. And today's event is really a chance to preview successes and challenges from different jurisdictions that have implemented MOUD in jails, prisons, and you'll also hear about community corrections, probation, and parole. So the hope of today's event is to definitely spur a conversation that can guide policy and practice in the immediate future. And next slide, please. With that, I can say thank you and turn it over to my colleague, Sachini Bandara.
Thanks, Brendan. So today I'm going to talk about the results of a study that we've done to understand the implementation of methadone and buprenorphine treatment in jails and prisons. Slide. First, I'd like to acknowledge my colleagues on the study, Alene, Kennedy-Hendricks, Sydney Merritt, Colleen and Brendan Saloner, as well as the funder, Arnold Ventures. Slide. There is a strong body of research and advocacy demonstrating how harmful the experience of incarceration can be to mental and physical health, and how the burden of this experience is disproportionately placed on communities of color in the United States. While jails and prisons shouldn't be the driver of our solutions to the current overdose crisis, given what we know about the effectiveness of this medication that Brendan shared, and that they are the gold standard in treating opioid use disorder and preventing overdose, and how few incarcerated individuals are given access to these services, we wanted to understand the experience of programs that do provide these medications in jails and prisons, and what lessons learned from their experience could influence the diffusion of these treatments to other systems. Slide. The focus of this study that I'm going to talk about is specifically on jails and prisons that provide opioid agonist treatments, methadone and buprenorphine, and facilities that both initiate and maintain at least one of these medications, meaning that they start treatment to individuals who were previously untreated, and they also offer to maintain opioid agonist treatments for individuals who were receiving treatment at the time of arrest. We conducted semi-structured interviews with leadership in jails and prisons that initiate and maintain at least one of these medications. And we interviewed 35 leaders on both the custody and medical side in 19 different carceral systems. This included sheriffs, wardens, medical directors, and senior medical staff. Our interview topics included the process of adopting and starting up these programs, the influence of policy on the implementation of these programs, the structure of these programs, and the outcomes of these programs. We conducted a thematic analysis of our interview transcripts using a coding scheme that was guided by the Consolidated Framework for Implementation Research. Slide. This table shows you some of the characteristics of those 19 systems that we interviewed. 14 of the 19 were county-run jail systems, 2 of the 19 were state-run prison systems, and 3 of the 19 were state-run unified jail and prison systems. 84% of the systems that we talked to offered both buprenorphine initiation and maintenance treatment services. In contrast, only 53% of the systems that we talked to offered both methadone initiation and maintenance treatment services. Slide. Our interviewees highlighted several policy-related barriers to the implementation of these programs. The first was the X waiver. So in order for a provider to prescribe buprenorphine for the treatment of opioid use disorder, they are subject to a set of regulations that are commonly called the X waiver, which places training requirements as well as prescribing limits on them. These restrictions are not unique to the carceral setting, but interviewees expressed that it really inhibited their ability to provide buprenorphine treatment, particularly in the larger carceral systems and in the early phases of their program as they were trying to get enough providers waivered. As one participant told us, get rid of the X waiver. I'm 100% in support of that. I think it's a ridiculous barrier that just inhibits our ability to address this problem. The regulations around providing methadone treatment were even more cumbersome. There are several federal and state regulations that require that methadone treatment be delivered in very specific ways and only by licensed opiate treatment programs. But the process of becoming a licensed opioid treatment program, as well as navigating and implementing all of these regulations, proved to be incredibly challenging for these programs. As one interviewee said, the process is extremely complicated. I have a few colleagues in county jails that have tried to do it, and they've been at it for 2 years, and they cannot get the license. So we have completely foregone that as an option. OTP regulations are the same whether or not a program is in the community or if it's in a carceral setting. And many interviewees felt that there was a mismatch in trying to apply the same standards in 2 places. One way that programs who did provide methadone worked around these cumbersome regulations was to partner with a community-based opioid treatment program that provided the methadone medication services to the incarcerated population under what was called the guest dosing agreement. Slide. These policy barriers, as well as stigma towards these medications and beliefs about diversion of these medications, really shaped the structure of these treatment programs in terms of how the jails and prisons designed their eligibility screening, how they dispensed medication, what requirements they posed on their patients, and what reentry services they were able to offer. I'm not going to go through all of these things, but I want to highlight a few very quickly. Slides. In part because of the regulatory requirements, dispensing these medications took a significant amount of staff and time and space. They were dispensed separately from other medications. It required coordination between custody, medical, and outside medical staff. And the programs that we talked to expressed over and over again that talking to other jails and prisons that were already implementing similar programs was really key in helping them figure out these logistical issues and barriers. Slide. Several of the programs that we talked to had program requirements that were not in line with the latest evidence base around providing these medications. For example, some programs set very low dose limitations for the medications that patients could receive. Others required patients engage in psychosocial therapy to receive medications. And some required patients undergo detoxification prior to the initiation of these medications. None of these elements are in line with the latest clinical guidelines, and were often set due to a provider or security leader's preference. For us, this really highlighted the need for some standards of care in providing these services within jails and prisons, and the need for education of carceral healthcare staff to ensure that these programs are operating in accordance with the latest clinical guidance. Slide. Ensuring that their patients had access to community-based treatment after release was a huge challenge for the systems that we talked to. Most programs made some type of follow-up treatment appointment at release. Even fewer were able to give people a bridge prescription, a prescription that they could fill in the community after they were released. And just 2 of the 19 gave individuals buprenorphine medication packs, so they had medication on hand after they were released to fill that gap between when they were able to access community-based treatment. The use of peer navigators, as well as having a robust community-based treatment provider system and connection to that provider system, was really key in facilitating and maintaining continuity of care for the patients in these treatment programs. Slide. Because so few prison systems offer these medications, many jails screened out individuals during eligibility screening who they thought would likely be transferred to prison. There was a lot of frustration on the part of medical staff that we interviewed who felt that they were not able to provide medications for individuals who were clinically eligible, who wanted to receive treatment, but were screened out because the providers did not want to prematurely stop their treatment due to a transfer to prison. Jails often use the criteria of having a felony charge as a way to screen people out. But one jail that we talked to actually removed this criteria after realizing that the vast majority of people with felony charges who they were screening out were not transferred to prison. So this is something for other jails to consider as well. Slide. Despite the challenges with launching these programs and implementing these programs, universally our interviewees felt that opioid agonist treatments should be offered in jails and prisons. As one interviewee said, "We are in the midst of the crisis still, and jurisdictions should be interested in starting services as soon as possible, not waiting until they think they have the absolute perfect program that is ready to be rolled out." Several interviews highlighted that litigation may soon force jails and prisons to adopt these medications whether they're ready or not. As one person said, every state knows the lawsuits are coming. It's going to come eventually. So do we want to get ahead of it and plan it ourselves, or be told how to do it? And finally, there was a feeling that acceptance of opioid agonist treatments was growing. As one sheriff told us, people who used to call me a drug pusher are now asking me, how do I get the program started? Slide. Ultimately, what this policy shows is that there are several policy barriers to implementation, particularly around medication dispensing and licensing, and these policies are not necessarily unique to the carceral system. Learning from other jails and prisons, as well as partnering with community-based treatment organizations, were really key in getting these programs up and running. And finally, reducing barriers to treatment and eliminating unnecessary requirements within these programs could be an important step in expanding the reach of these programs and making sure that they're in line with the latest clinical guidance. And I think finally, the biggest thing that we want to reiterate from this study is that it is possible to initiate and maintain opioid agonist treatments in a variety of jail and prison settings, and acceptance of these life-saving medications is growing. So with that, I'll say thank you, and I will hand it off to my colleague, Krawczyk, who will talk about a statewide initiative to expand access to these medications in county jails.
Thanks so much, Sachini. Hi, everyone. My name is Noah Krawczyk, and I'm an assistant professor at the NYU Grossman School of Medicine. And I will be speaking particularly about another study we conducted related to barriers and facilitators to implementation of a statewide MOUD treatment initiative, particularly in jails in New Jersey. Just before we start, just want to acknowledge Bloomberg Philanthropies for funding this project and our many collaborators at Johns Hopkins, Pew Charitable Trust, and the New Jersey Department of Human Services, as well as the New Jersey Wardens Association. Slide. So just some quick background, particularly why jails are different than prisons and the criminal legal system in general, is that jails face particular challenges to their MOUD implementation, and this is largely due to many factors, but two in particular. One is that jails are decentralized, which means that they are governed by localities. So a state, for example, does not have jurisdiction over a specific jail within a city or a county. We also know that the grand majority of people who are in jail are actually pretrial. So there's a lot of rapid cycling of people in and out of jails, and also people are there with unpredictable lengths of stay, which makes it more difficult to plan someone's treatment for any health condition, and particularly for MOUD. And we'll talk about that a little bit today. Next. So this study, we particularly focused on one statewide initiative to encourage use of medication treatments across county jails. And we were particularly interested in learning about the challenges to implementing medication treatment in these settings, as well as some of the innovative strategies that some jails have used to facilitate their uptake. Next slide, please. So the context here is that New Jersey in 2019, the state government actually provided grants to local county jails to support expansion of their medication treatment. So even though they couldn't mandate this, they encouraged expansion of medication treatments through this grant funding. At the same time, in 2017, New Jersey went through a bail reform, which removed bail requirements, and this actually reduced the average jail stay from about 7 days to a little over 3 days on average. So this also changed how things were conducted within the jails. And so to learn about this process, we conducted interviews with leaders of 11 New Jersey jails that were undergoing implementation of medication treatment at the time. Next slide. So we conducted semi-structured qualitative interviews, and we particularly focused on 3 questions. First, related to the current capacity and practices that were used to deliver medication treatment in the jails. The second were about primary challenges to delivering these services, especially in the context of bail reform and short jail stays. And third, we wanted to learn about strategies that they have found to have facilitated delivery of these services. So we transcribed and coded these interviews using a hybrid approach. And finally, we came up with 5 large themes in our thematic analysis that we'll briefly go over today. Next. So the first theme really related to the fact that capacity and practices for delivering medication treatment varied drastically across the different jails in the counties of New Jersey. Next. And what this looked like was really in a few different aspects. So first, clinical practices often were based on provider preferences of that particular jail rather than expert clinical guidance. We also learned that there was a lot of mixed practices, specifically related to whether counseling should be mandated or just offered as an option in addition to medication treatment. We also heard that there was a lot of variation in the capacity and quality of medical record keeping and reporting around medication treatment programs. So just to give one quote example from this theme, next slide. One jail participant said, MAT itself as a singular act is a pointless gesture without the talk therapy to go along with it. So even though we have a lot of evidence that medication treatments are effective even without counseling, in this particular jail, there was a strong sense that counseling should be mandated as part of treatment. Next slide. The second theme really related to the limited resources and highly regulated operations that often challenge the delivery of medication treatment behind bars. So here we really heard two different aspects of this. First, that managing medication treatment behind bars is extremely time and resource intensive, and particularly that the limited resources were reported as a barrier to medication treatment operations. And so to give one quote example about this topic, one person said, well, I mean, I think on the table, we all know what the elephant in the room is. It's funding. That's the biggest challenge. If we had the funding, we could certainly expand our program. So here we see that even in the context of New Jersey that was providing more funding to expand these programs, many jails felt like this was still insufficient to really provide the services to the quality that they would like to. Next slide, please. The third theme related to short jail stays and how the criminal justice reform, which is New Jersey's version of bail reform, how these conditions created a very slim window to provide medication treatment services. Next. So we heard that the MOUD intake process was often lengthier than the jail stay itself under criminal justice reform, since many people were there for very little amount of time. And we also heard that these short jail stays even challenge the ability to initiate certain types of medication treatment. So as an example of this, one person said, we don't intend to start Suboxone here, buprenorphine here, because of number one, time constraints, and number two, time constraints. I mean, the average stay will probably be 3 days. It's because they come in and out, which is different from the prison system. So here we really heard that many jails were hesitant to even go through the process of providing medication treatment because they were unsure when somebody might leave, and they could often leave even before they could get into the process of initiating treatment. Next slide. The fourth theme was around limited availability of community-based medication treatment, which limited the linkage of people to care once they were leaving the jail. So a couple of different themes within here is that first we heard that there was difficulty identifying providers in the community in the first place to refer people to upon release. And often that this lack of community care led to reluctance to even initiate or deliver medication while people were still in jail. So as an example of this, we heard from one participant, let's say if they get discharged after 4 or 5 days, there's really no place for them to go because of the availability of resources outside. So there's really a sense of hesitation around what the jail should be doing when people couldn't even get into treatment once they were released, or that was the sense that many of these jails had. Next slide. The last theme I'll talk about was really about facilitators and creative solutions that jails had for delivering medication treatment, even in the face of the many challenges that were brought up. So this took a few different forms. The first was really around speeding up the MOUD intake process, given the reality of the short stays that many of the jails were experiencing. The second was around providing bridge medication prescriptions at jail release. And this was often done to ameliorate some of the issues around of where to refer people to care upon release. And last, was that we heard about some efforts to address conflicts. So for example, related to medication diversion, that's often cited as an issue within jails with education and understanding. So to just give one example of a jail that mentioned this, We heard, we start medication as soon as they're clinically qualified. We don't use jail times, transfer dates, time close to release as prerequisites for treatment. So here, this jail really wanted to speed up the intake process because of this nature of short jail times. Next slide, please. So just to give some quick summary points and implications, the first is that we heard a lot of variable practices that were being taken in the jails, and this really relates to the need for standardized guidelines around what's really the most evidence-based care related to medication treatment provision. The second was that there really is a need for consistent allocation of resources to sustain medication treatment management, as well as effective data reporting to be able to look at the effectiveness and outcomes of these programs. The third is that efforts to increase jail-based medication treatment still require increased community medication treatment as part of these efforts, and also to increase jail community provider partnerships so that there is a clear pathway for people to be referred to treatment upon release from jail. The fourth point is that while bail reform reduced length of stay, there really was still a sense that there was high volume and turnover in the jails. And so there really needs to be other criminal legal system reforms to reduce jail volume as well as jail length of stay. And lastly, we know that there's likely no one-size-fits-all solution, but we did hear that jails could creatively address challenges through multiple different strategies, and that they could potentially share these successful lessons with each other as a lot of jails learn to adopt these programs. So with that, I will end there, and I will pass it over to our last presentation by Alene Kennedy-Hendricks.
Hi, everyone. So I am going to shift gears a bit from the jail and prison setting to focus on supervision in the community. And by community supervision, I'm referring to a range of settings that include residential community supervision facilities, as well as situations in which people are living independently in the community, but regularly report to a probation or parole agency. Next slide, please. Okay, so over 4 million people in our criminal legal system were under supervision in the community last year. And substance use disorder treatment is often mandated under the terms of community supervision sentences. And we know from prior research, including work by Dr. Krawczyk, that a small minority of referrals from probation and parole agencies for opioid use disorder treatment result in treatment with opioid agonists like methadone and buprenorphine. So the research I'm presenting today focuses on the structural and organizational factors influencing use of medications for opioid use disorder in community supervision. So next slide, please. So this study is really an extension in some respects of Dr. Bandara's work with a shift in focus to this other setting. So I'm not going to go into much detail with respect to the methods, apart from noting that our sample included 31 individuals who mostly held leadership roles in local and state community supervision agencies from 17 unique states from across the country. We also had interview participants from the community supervision arm of a corporation that contracts with local and state governments in over 20 states. The themes I'm going to focus on today include the external factors or factors outside the community supervision agency that influence opioid use disorder medication use, the cultural orientation of community supervision agencies, and the relationships between community supervision agencies and substance use treatment providers. Next slide, please. Okay, so the primary external influences on medication treatment emerging from our interviews included treatment providers, judges in the courts, jails and prisons, and the sources of financing for treatment available within jurisdictions. One theme emerging from our interviews was this perception among community supervision agencies that they were generally deferential to the expertise of treatment providers with respect to treatment decisions, such as the use of medication. So this quotation here illustrates this theme, with the interview participant stating, "I would say that's just up to the provider. We don't get involved in the medication part." And I'll discuss in a few slides how this perception that agencies seem to have about their deference to treatment providers is complicated by the role they play in determining which treatment providers to work with in the community. Next slide, please. Generally, interview participants described the judges and courts' roles mainly as mandating assessment for treatment rather than specifying the modality of treatment. But participants also mentioned exceptions, such as judges with preferences for particular providers or biases toward medications like methadone. For jurisdictions with drug courts or other specialty courts like mental health courts, these courts were not necessarily more receptive to medication than the other non-specialty courts, as noted by this quotation here. Next slide, please. So the majority of participants were located in states that had expanded Medicaid to the broader population of low-income adults under the ACA. And in these expansion states, Medicaid was viewed by most participants as a real game changer. And together with federal grants, such as state opioid response grants, participants felt that these expanded financing mechanisms had helped to catalyze medication availability in the community and expand the supply of providers that offer medication. Next slide, please. We identified several cultural orientations relevant to this topic. In the interest of time, I'm only going to focus on two. So the primary way in which a more rehabilitative orientation emerged in the interviews was through participants expressing this idea that community supervision agencies had become more understanding of the process of recovery than they had been in the past. And this particular quotation suggests sort of a recognition that recurrence of use is expected, and the response is, how are we going to support you more? And then there's a lot of tweaking going on with those medications to find out what works right for the person, as this participant expressed. And this idea that recovery is a process and can involve recurrences of use was fairly common among our interview participants, but less commonly expressed was this latter idea that the process of recovery translated to a need to kind of adjust medication or treatment and response rather than respond punitively. Next slide, please. So because people under community supervision are subject to intense surveillance, the issue of drug testing and the consequences of positive drug tests came up frequently in our interviews, particularly in relation to sort of these more punitive orientations. So one interview participant explicitly stated that the use of drug testing had been in the past and continues to be a way that agents frustrated with someone under their supervision can move that person off their caseload. In another jurisdiction, this system operated under a swift, certain, fair model, which mandated short 1 to 3 day periods of confinement for positive drug tests, which posed a real challenge to continuity of medication treatment, despite sort of other efforts in this jurisdiction to expand engagement with treatment in community supervision. Next slide, please. So finally, I'm going to talk about sort of the key interorganizational relationship that we explored in these interviews, which was between the community supervision agencies and treatment providers. So participants reported quite a bit of variability in availability of medications among the providers with which they had relationships. So this inherently restricted whether or not medication was even an option. Relationships were often formalized through contracts with providers and agents, between providers and agencies, or through more informal referral networks. And there was a general reluctance among interview participants, speaking sort of from the agency perspective, to impose requirements related to medication and the contracts that they did establish with treatment providers or with other partners, like transitional housing, for instance, that might bar people with medication, receiving medication treatment from participating in those services. And so this first quotation sort of expresses this sense that making this a requirement would not be effective or elicit desired outcomes. And this seemed to be mostly related to concerns about just sort of not having a sufficient sort of number of providers more broadly, and being concerned about risking those relationships. Interview participants expressed challenges also with respect to compatibility with treatment providers, such as having limited residential treatment options that accepted people being treated with an opioid agonist medication, particularly methadone. On the other hand, some felt that the treatment providers with which they worked were really aligned philosophically in terms of requiring use of other therapies in addition to medication among people with opioid use disorder, which is an issue raised in the other two studies presented today. So some key takeaways. While interview participants viewed themselves as deferential to the expertise of treatment providers, we also know that most substance use treatment providers in the US don't offer medication for opioid use disorder. So this deference felt a bit misplaced. Community supervision agencies do have influence in the relationships they cultivate, who they contract with, and the terms of these arrangements, who they're referring to for treatment and so forth. And so there are real opportunities here for agencies that do value medication to leverage their relationships with providers to improve medication access. In addition, there are opportunities in turn for community treatment providers to educate community supervision agencies. Work by Peter Friedman and colleagues, for instance, has demonstrated the effectiveness of organizational linkage interventions in improving community supervision agency referrals to medication. Broader reforms, though, to the substance use treatment infrastructure to make medication more available and more a core component of treatment programs would likely have ripple effects on accessibility among people under community supervision, and perhaps make the job of community supervision agencies easier in the sense that they could refer to treatment providers knowing that medication actually was an option. As we learned from Dr. Bandara and Dr. Krawczyk's presentations, there is a tension between community supervision and best practices for medication treatment. So agencies that seem to lean more towards a more rehabilitative orientation did view medication more positively, but still had misperceptions of sort of the best practices regarding medication use, including the long-term use of these medications and not forcing or encouraging tapering. And not making medication contingent on participation in other forms of treatment. However, if treatment requirements remain the norm in community supervision, which seems likely in the near term, judges, courts, and community supervision agencies need to be trained on the risks of making medication access contingent on participation in other forms of treatment. A cross-cutting theme was methadone stigma, and I just wanted to touch on it briefly. So methadone was widely viewed among participants as sort of old-fashioned or a red flag, that people weren't serious about their recovery. And most partnerships mentioned by interview participants were with non-opioid treatment program providers, although there were certainly exceptions. So there was a real need here to strengthen relationships between agencies and opioid treatment programs and improve understanding of methadone. And then finally, Medicaid is really critical in terms of sustaining access to medication. So while these federal grants were viewed by participants as sort of catalyzing availability of medication, these are time limited, and in contrast, Medicaid financing and expansion states should be more sustainable over the long term. So to wrap up, these interviews reveal numerous avenues for improving uptake of medication for opioid use disorder in community supervision settings. And I'll hand things off now to the other participants. Thank you.
I think now we're going to transition into our reactions, and I think we'll start with Alex.
Great, thanks so much. I'm Alex Duncan from the Pew Charitable Trust Substance Use Prevention and Treatment Initiative, and I really appreciate the opportunity to provide some remarks about the research presented. There are a few policy-related themes across the presentations that I want to lift up. But first, let me start with a couple of challenges jails, prisons, and community supervision agencies face in providing or supporting the use of MOUD. And these challenges include, but are not limited to, inadequate data reporting on MOUD provided in prisons, jails, and community corrections, ex-waiver limitations, unanticipated jail release dates and times, and stigma towards OUD and MOUD in all parts of the criminal justice system, including drug courts. Policymakers can be a part of the solution to all of these challenges. Dr. Saloner mentioned recent data from Brown University on the number of correctional facilities that provide MOUD. These are the numbers we need to know, and they need to be updated continuously. OUD questions were included on the 2019 Census of Jails. Pew provided comments to the Bureau of Justice Statistics on these questions, and this is a step in the right direction. Policymakers can ensure agencies have the resources to collect and report these data. Dr. Bandara reported on several areas where policymakers can offer support, but I want to highlight the X waiver. The X waiver is an important issue to Pew because we believe the elimination of the X waiver will increase treatment availability. The X waiver is relevant for prison and jail clinical providers since these providers must also have the waiver for OUD treatment. And turning to policy solutions, there's the Mainstreaming Addiction Treatment Act sponsored by Representative Tonko, also known as the MAT Act, that would eliminate the waiver altogether. In late December, an early version of one of the COVID relief packages included a provision that would have created a one-year moratorium on the X waiver, so not a permanent repeal as in the MAT Act, but a one-year reprieve. And this provision was included in a public draft released by a bipartisan group of senators, but was taken out at the last minute. But new legislation was reintroduced on February 25th, 2021. There was a congressional briefing on the MAT Act on April 7th that went really well, and there's a congressional hearing tomorrow. Dr. Krawczyk's presentation on New Jersey was insightful for two reasons. One, the state implemented criminal justice reform that affected jail length of stay and thus how quickly jails could provide MOUD. And two, the state provided jails direct funding for MOUD and reentry programs. More jurisdictions are implementing criminal justice reform and will need to learn from New Jersey on how to provide services when individuals may be in the facility for fewer than 48 hours. While the funding from the program came from the New Jersey Department of Human Services, Division of Mental Health and Addiction Services, state policymakers can have a hand in ensuring there's continued funding for these programs. As many know, federal insurance programs such as Medicaid are not billable when an enrollee is incarcerated. There are some policy efforts to change this by amending a section of the Social Security Act to allow for the continuation of benefits. The Medicaid Re-Entry Act would allow Medicaid payment for medical services provided to individuals who are incarcerated 30 days prior to release. Medicaid Re-Entry Act language failed to move forward in the American Rescue Plan Act of 2021, but is still alive as a separate bill, and there's a hearing on the Medicaid Re-Entry Act tomorrow. Dr. Kennedy-Hendricks provided the community supervision perspective. And this is so important because data from the Bureau of Justice Statistics shows that there are many more people under community supervision as compared to individuals who are incarcerated in state and local facilities. Given this, it's important that community services are welcoming to individuals under supervision and that those who supervise are educated on MOUD and OUD. And policymakers can support the growth of community services. For example, Indiana has a legislative moratorium on the number of opioid treatment programs in the state. Putting aside opinions on moratoria, the Indiana legislature increased the number of OTPs permitted in the state, and the state has been working with community providers to open those OTPs. Increasing the number of OTPs will surely increase access to treatment. And lastly, and most importantly, I want to leave the presenters and us to think about the role racism has played in the disproportionate number of people of color who are incarcerated and under supervision, particularly for drug-related crimes. Therefore, solutions must keep equity in mind. And thanks for the opportunity to provide these remarks.
That was excellent, Alex. Thank you so much. And now we'll turn over to Tyler.
Hey, everyone. Thanks for having me today and for letting me join. I'm Tyler Winkleman. I'm a primary care physician and researcher at Hennepin Healthcare. I'm calling from my jail health clinic today. And then I also co-direct the Health, Homelessness, and Criminal Justice Lab in the Hennepin Healthcare Research Institute. There's just been an amazing amount of information in this webinar so far. And I think maybe what I can do here is just provide a little bit more clinical context as we think about policy and system solutions for expanding access to MOUD in jails and prisons. So I think one of the things I wanted to say, a lot of this probably is not going to be new to many of you on this call, but that is that, you know, even though the X waiver is expanding and more people have gotten it, there are still a lot of providers who have no training in how to do this. And even for the folks, and that is particularly true for providers working in jails and prisons, and even for the people who get their X waiver, they often do not feel confident. And so in our, because we're the largest jail to roll this out in Minnesota, we provide a lot of technical assistance to other jails, sort of just pro bono, to help other people get off the ground. And it is really helpful for jails and prisons starting out to have some type of support. Most jails also don't have a provider every day. They might not even have a provider every week, or maybe for a half day a week, something like that. And so some other solutions using telemedicine are incredibly important. And then this period of time when people start medications when they're in jail or prison is a really monumental moment. People don't often come in saying, you know, I'm really concerned about my opioid use disorder, and I think I'd like to start buprenorphine today. That does happen. But a lot of times patients might be ashamed. They might feel hopeless. They have never been told about MOUD. They know nothing about it. And so it takes a system that really is able to understand where an individual is at and has the time and resources to provide that education in a non-stigmatizing way. We have many patients who have never heard of medications for OUD, and it takes time to review the options and the science around the medications. And for many people, it's the first time they've had a discussion about their substance use without immediate judgment and stigmatizing language. And so the ability for jails and prisons to both offer the medication, but also have staff training in how to do this is really, really important. A couple other things. It's very rare that we see someone who is only using opioids. Often it is occurring along with methamphetamine use in probably 75% of the patients that we start on MOUD. And then there's often other types of substances involved as well. And we should be thinking about what that means in terms of the supports for when people leave jail. And then finally, two other points. Once people are stable on their MOUD, it is super common for flashbacks and PTSD to really rear their head. And having mental health treatment in place to go alongside MOUD is very, very important. Certainly MOUD is effective without counseling, but there are often co-occurring mental illnesses that do need treatment in addition to the MOUD. And then finally, I would say, as we rolled out our MOUD program, we really tried to address stigma across the criminal justice system. And that took a lot of effort. And I think basically that attempt at culture change helped our program succeed. And so we had innumerable conversations with our county prosecutors, with the public defenders, with the judges, with community corrections. And that took months and months. We got started right away. But then as we rolled out the program, we really tried to address stigma throughout the criminal justice system that I think has helped our program mature and grow. So those are a few of my comments, and look forward to the conversation ahead.
Great. Thank you, Tyler. And maybe Alex, if you can join us too. Let's do one question just with our two discussants, and then we'll segue for our last few minutes to bring the rest of our panelists in. So very quickly, both Tyler and Alex, you both touched on stigma. Both, Alex, as you said, the stigma of substance use disorder and people with substance use disorders, as well as the stigma attached to life-saving medications for opiate use disorder. So one question that's an obvious one in a conversation like this is sort of these barriers or these things that people can't do or don't want to do. And Tyler, you described a very long, involved effort at education to overcome stigma. What are the sort of most immediate things that we can do in these settings of care to rapidly address stigma? And Alex, to your point, in some cases, the multiple stigmas when we think about race and racism in these systems as well. How can we tackle stigma in this setting? Alex, why don't you start?
Yeah, I mean, it is quite challenging. Thankfully, opinions are changing. As one of the quotes that one of the presenters showed, that people have changed some of their perspectives on the medications. Education is very important. I want to highlight something from New Jersey is that the New Jersey Department of Corrections trained all of their correctional officers across all DOC facilities on MOUD and OUD, and that training included stigma. So trainings and investment in activities such as that help move the needle. And then there's folks like Dr. Winkleman, and that are champions and advocates for patients who are incarcerated and recognize that the standard of care in the community is the standard of care within corrections.
Yeah, thanks, Alex. I think obviously there's no simple solution here, but one of the things that we really try to do is to match our actions with our language. So we often talk about OUD as a chronic disease, right? But then if you look at how some people treat it, it's a separate line, it's not administered with any of the other medications, there's all these rules around it, and then when we talk about it, we say, oh, you failed or you relapsed. Imagine if we talked about diabetes, if we said anyone with diabetes, you need to go to this special line, and if your A1C, if your blood sugars go up at all, you've really failed, and we're just going to have to stop your medication because you forgot a couple of days of your diabetes medications. And so we really try to treat OUD as the chronic disease that it is. So we give the medications with other medications. We don't separate people out to receive the medication. And then we also try to be very careful in how we talk about it, both with our patients, with our staff, and with our partners in corrections. So that I think has been a very intentional component of our program, and something that I think is important in treating OUD in the way that the science tells us it should be treated.
That's excellent. Thank you, Tyler and Alex. And now I'd like the rest of our panelists to join. And I'm gonna, because our panelists have been just fantastic at responding to the questions as they come in, and we only have about 5 minutes left. I'm going to take the prerogative of the moderator to ask a discussion question, and I'm going to direct it first to Brendan and then open it up to the broader panel. So much of our conversation has been about getting more facilities to offer MOUD, but what we really want is these facilities to be offering best practices. And we know there are lots of barriers that are limiting access and best practice in jails and prisons, including tapering requirements, low dosing, and importantly, counseling requirements. Brendan, first you, and then others can chime in. What do you think are the best ways to lower these barriers?
Well, I'll take a start on that, but I would welcome others to chime in as well. I think that it's really about moving toward a low threshold treatment model. So we've seen some facilities going in this direction. I saw a good comment in the chat from someone in New York City, which I think is an example of really being able to do treatment at volume by bringing in a lot of other people, starting people quickly on medication. I think Noah's point about the New Jersey jail that kind of tried to streamline their start and intake process to make medication very, very quick and timely. So I think that these high volume facilities give us a clue that this is possible. One of the things that we learned in our research is that even facilities that are doing this are really doing it in such small numbers that it's not having the public health impact we'd like to see. But I want to hear what my other panelists have to say.
Who else would like to chime in on this one?
I think there's also a component, an education component that is needed here. Several of the providers we talked to had really strong beliefs about dosing, about therapy requirements, and there was a sense that there wasn't, in some cases, an awareness of what the latest clinical guidelines are. So I think that is also one key piece. And I think there's also, we need to recognize that the medical providers working within these systems are also balancing pressures from other entities like security entities and courts and judges. And so maybe providing them some education to those types of entities also is warranted to kind of relieve some of the pressure that the medical staff is facing to put some of these restrictions in place.
Great, thank you so much for that, Sachini. Tyler, did you want to jump in here?
Yeah, I was also going to say, you know, I think some of this is also related to how healthcare in jails and prisons in the United States is regulated. So often sort of the department overseeing the healthcare agency in a particular facility is a correctional leader. And in most other countries, the authority overseeing healthcare is a healthcare entity. And so, you know, a lot of these decisions, healthcare decisions are being run through a correctional leader. And so, you know, correctional leaders have often lots of other priorities. And it's not necessarily always about, you know, not thinking it's a good idea, but sort of the order of prioritization. Whereas when there's oversight of a healthcare agency, by a healthcare agency, sometimes these priorities can shift.
Great, thank you. So we have about 2 minutes left, so I'm going to throw out two quick questions and folks can answer them in whichever way they choose. The first relates to Medicaid and the second relates to methadone. So with Medicaid expansion, this has been a major source of coverage for people leaving jails and prisons. What do you think Medicaid can do to improve care during reentry? And the methadone piece is that we've really seen this flat line in terms of access to methadone in communities. Big increases over time in access to buprenorphine, but one of our major tools just has not changed in terms of access within communities. Please take on one or the other of these topics during our last minute or two. Who would like to start?
huge questions we don't have enough time to answer. I think Medicaid expansion, we are at another pivotal moment with the new law passed by Congress, and great opportunities for some states to come along and start expanding Medicaid again. And I think if you are in one of those states, especially working in a carceral facility, you have an important story to tell people in your state about the impact of Medicaid on a very high-risk population.
Thanks, Brendan. Tyler or Alex, any final words for our presentation as our discussants related to those questions?
Yeah, one last comment about Medicaid is that having Medicaid promptly reinstated upon release is very important for reentry-based care. And what we've seen is prompt varies across jurisdictions. And so that's something that states want to look into a little bit more. Great,
thank you. And Tyler, last word to you.
Yeah, I would just say that the issue of the Medicaid exclusion policy is both practical and philosophical or cultural, in that by limiting Medicaid funds, it not only makes it harder to fund those programs, but it has functionally completely separated healthcare in jails and prisons from the rest of the healthcare system. And so in addition to Medicaid being able to pay for these services, there does need to be this culture shift of bringing what happens in jails and prisons back into the healthcare system at large, and recognizing, as COVID has shown us, that sort of what happens in jails and prisons is important in the community, and what's happening in the community is important in jails and prisons, and we can't separate the two.
We'll leave it there. On behalf of our Center for Mental Health and Addiction Policy, thank you to all of our panelists and discussants today for this incredibly important conversation. And this recording will be available on our website within a few days. Have a great day.